Well, welcome to DH316 Online. I'm going to do my best to review the PowerPoint lectures with you guys, give you some extra tips and tricks. At the end of the lecture, if you have any questions for me, please email me through BBLearn. I'll do my best to answer them, but I'll probably answer them under announcements because if you're having a question, the whole class might have a question. So we're going to just kind of work it that way. That way I make sure that everybody understands what's going on. Okay, this slide is just kind of furthering the story of Jack and the house that he built. And up until spring break, we had been talking about all of the factors that play into periodontal disease. The inflammatory response, calculus, plaque, all of those factors that lead to periodontal disease. So now we're going to start transitioning into what we do every day as a dental hygienist, and that is treating the disease, arresting the disease, and trying to teach our patients how important it is to keep up with their cleanings and to keep their mouths healthy on the inside. Non-surgical periodontal therapy. Well, what is it? It's what we do every day. It is the plaque control measures that we take when we talk to our patients. It's the actual instrumentation process using our hand instruments, hopefully our ultrasonic soon for you juniors. And then moving into summer, you will learn some of the chemical agents that we can use topically and systemically to help kill that bacteria that's in the pocket and keep the infection at bay. Along with being called NSPT, non-surgical periodontal therapy, there's also some other names that you might run across in textbooks, articles, journals of that nature. These are just some examples of the other names that it's called. The most common one that I come across these days is phase 1 therapy. That's an older term that you may run across, but it's one that you probably should know. It's a synonym. It's if you hear phase 1, that is what we're doing. That's when you're doing your probing, you're taking your assessments, you're diagnosing the disease, and you're implementing chair-side treatment that you can do in the office that day, or maybe with some anesthesia, but it's at your skill level. It's not needing, the patient doesn't need surgery. It's just we're going to clean their teeth to the best of our ability, and then we're going to reevaluate. But phase 1 is the initial assessment phase, same as non-surgical periodontal therapy. So some of the objectives or goals of phase 1 or non-surgical periodontal therapy are listed below. Basically, we want to reduce inflammation, reduce bleeding, prevent or stop bone loss. So part of our job in treating the periodontal diseases includes, treatment planning, which you guys have been working on in clinic. But remember that every patient is different, and the primary etiological factor most destructive to tissue is bacteria and plaque. And with that comes local risk factors. We need to always, when we're planning our treatment, we need to also look at our x-rays. Are there bad margins? Are the plaque traps there? Are the overhangs there? And then we also need to review our medical histories. It's very important, let me back up. It's very important to review the medical history at every appointment. I cannot stress that enough because people and patients, they change, they can go to the doctor and something can change from Monday to Friday. So it's really always important to review the medical history and look for systemic risk factors. A big one up in northern Arizona, of course, is the diabetes population that we have here. And I think we've looked at pictures enough to know that, diabetes does wreak havoc in the mouth. So, it's just important to review that, and it's part of our treatment plan as well. Okay, so this top picture should look familiar to all of you. We should be doing or disclosing at every appointment to check for plaque reduction, or if their plaque is increasing throughout treatment. The book states that the plaque is the major etiological factor in periodontal disease, and it's our job to show the patients how to remove it. All right, these are the steps that we take when we are treatment planning our patients. Of course, we always do patient education, OHI. We might treatment plan an adult prophy or a scaling and root planing procedure. We're going to remove the local factors and carious lesions. Anti-infective therapy, that is pharmaceuticals, antibiotics, antifungals, etc. We cover that more in DH 419 next semester. Post-modulation therapy has to do with localized antibiotics, such as Arestin. I do believe that you learn how to place Arestin during the summer, and you'll cover that, I believe, in Mrs. Smith's class, but we do cover that more in DH 419. It's also our job to monitor, occlusal adjustment needs. If a patient is biting down incorrectly, it can lead to abfraction, it can wear the enamel away. So we can help monitor that situation and call the dentist in to come remove some tooth surface if need be. Also, we look at their orthodontic. When you see a patient with orthodontia come in, it's a whole different way to treat the patient. It's hard to clean around brackets and wires and braces. So it's just a different way that we have to go about with that particular patient. And then the reevaluation appointment, and I believe that is in a lecture coming up in the next week or so. This slide is just showing the reasons why non-surgical periodontal therapy works. It's why we've been doing it for many years. It's effective, it's cost effective for the most part. It's easily repeated, meaning it's a process we can do every 3 to 6 months, depending on the patient need. It can be performed by hygienists. You don't have to have a dental license to do non-surgical periodontal therapy. It's tolerated by the patients well. We do offer local anesthetic, which you learned this summer. And for the most part, the patients, the post-operative portion is low. The patients recover well, 2 to 3 days, they feel better. They're bleeding, bleeding is minimal. It's chairside, there's no general anesthesia involved. The patients respond well, the healing time is quick. With non-surgical periodontal therapy, there's no gingival flapping required. That's when we would send the patient to the periodontist and they would flap it. You would see the underlying tissues that way. So, this is just proven to work for most patients. Well, how do we know who qualifies for non-surgical periodontal therapy? Well, in our clinic, most likely it is our patient with plaque-associated gingivitis or chronic periodontitis. So it's your standard patients, it's your SRP. Again, I can't stress enough, it's patients that you can handle with your skill level chair side. You don't need additional help from a periodontist. Sometimes we're asked to perform SRP or a cleaning, if you will, for patients before they go into surgery, just to kind of help get the bacteria out of the mouth, to get the plaque and calculus buildup out of the mouth before they go in for surgery. And in case you didn't already guess, the patient that we should not be treating with non-surgical periodontal therapy is the patient that has aggressive periodontitis. Those patients most likely need to be treated by a specialist. And especially if they're young, they need to be treated ASAP. Okay, so here are the goals laid out for you to read of NSPT or phase 1 therapy. Of course, we talked about, reducing the bacteria in the mouth, eliminating risk factors such as overhangs and such, reviewing their systemic issues, getting that under control, sending them to a referral if we need to. Of course, our big job is stabilizing attachment levels. How do we know that what we're doing is working? How do we know? Well, the only way to know that what we're doing chairside is working is to complete a reevaluation of the patient. You bring the patient back in, you reprobe, you look in their mouth, and you check to see if things have gotten better or if they've gotten worse. This is an important step in treatment that often gets overlooked. We'll talk a little bit more about this later. Okay, so basically we're kind of at the point in the lecture where we're going to start talking about instrumentation as part of the treatment. This is kind of the fun part, the meat and potatoes of it, you know, different tools we get to use, different ways to talk about OHI, different products to get your patient to try, and antimicrobials, of course, you know, we're talking about chlorhexidine and such like that. And at this point, as part of the non-surgical periodontal therapy, is also part of that correction of risk factors is also your tobacco cessation. So if they're smokers, if they're using any kind of substance, this is when that would come into play, because I know you guys are doing your MI process evals, your tobacco cessation process evals. And you know, I know they get annoying. I've been there. I've been a student. I've listened to hundreds in the last 6 years. But they are important because it's part of our job. A lot of times, dental care providers are the only healthcare providers that some patients see. And so if you know your patient is nutritionally deficient, using tobacco, using some other form of substance, you know, it's our job to kind of give them a little push, just question them, ask them if they're interested, not lecture them, but you know, that is part of our job, and that is part of the non-surgical periodontal therapy, as well as the mechanical removal or debridement of plaque and calculus. So we've already talked in lecture face-to-face about how toothbrush bristles can only get, you know, so far down into the pocket. So, you know, the major objective of instrumentation chairside is to reach where the client or the patient cannot get with their toothbrush or even with their floss. We want to disrupt that bacterial colony. We want to break it up. We want it to go away. We want it to stop making friends. You know, physical removal of bacteria is the most effective mechanism of control. Physical removal using a hand instrument or an ultrasonic is the best way to get plaque and bacteria out of the mouth. Can't stress that enough. What I like most about this slide is it kind of reminds us that a positive of dental instrumentation, especially when we can get down to the base of the periodontal pocket, is that it induces the change in that subgingival bacteria flora. Because remember that not all bacteria are bad. We need good bacteria in our mouth as well. And so when we are getting down there and we're scaling to the base of the pocket to the best of our ability, we're breaking that up, we're helping to eliminate inflammation and all of that. But it also gives the chance for the early colonizer, maybe, the better bacteria to kind of repopulate. So just don't forget about that not all bacteria are bad, but part of the instrumentation is that we kind of help to kind of turn over the bad bacteria so the good bacteria have a chance to come in. Okay, because of our current situation, the slides show the lectures are a little bit out of order, so bear with me, but you have a assignment where you're going to research the differences between ultrasonic or hand instrumenting, okay? So when you're doing your non-surgical periodontal therapy, what tool is best? Well, you're going to do some research on it, and if you go to BBLearn, I have a paragraph of instructions on what that assignment kind of leads to. Although I will let you know, it's highlighted in red here on the slide, that power instrumentation is the choice over hand instrumentation, according to Neil Garrick and Willman. And I do believe this is your book that you use for clinic. But I want you to do your research, and I want you to tell me why you think that. You know, why do you believe that power is better or maybe not better. This is just one opinion from one textbook. And I think that what you'll find over the course of your studies and being a professional is just because one textbook says this, another textbook might say something different. So it's basically, your choice. And I'm not going to like guide you or lead you, but I just wanted you to know that, power instrumentation, and I'm so sorry you guys have not got to use your ultrasonics yet. I think it will come. I'm hoping that in the summer that things will be better and we're able to teach you how to use these instruments. But these are some things that we've proven that power instrumentation can do. The way that the tips are built, they're really slim and narrow and they get really good into the pockets. We have a low, a medium, and high power settings. It helps reduce damage to root surfaces. Sometimes when you're hand scaling, you can really dig in there and gouge your root surface. You have to be careful. And also, I think a benefit of the power hand instrument is that it is giving that water irrigation. You're removing toxins. It's lysing bacterial cell walls just from that movement. So I went ahead and I left the slide in. I'm not trying to lead you into your decision on the discussion board posting later because it's just something that I know your textbook talks about. Well, here is a list of pros and cons when talking about hand curettes or sickles versus your ultrasonic or your piezos. Again, the number one pro to a hand instrument is it doesn't admit any kind of aerosol into the air. So we're not putting that bacteria or anything into the air, any disease up into the air for other people to breathe in. And of course, in the state of the world that we're in right now, that's a pro, that's a major pro. And one of the reasons why dental as a community is shut down right now because of that aerosol that we make when we're doing any kind of dental work, elective and non-elective. Hand instrumenting, you do have better tactile sensitivity only because when you're using an ultrasonic, you are holding that instrument very lightly, almost like you hold an Explorer. So you really are counting and you're really depending on the machine itself to do the job for you. So you're really holding it very lightly. So these are just some pros and cons. Again, for power instrumentation, there is a tip that you can use on implants, but it's not very good. It's plastic. I don't recommend that. I recommend scaling implants with titanium instruments. We'll talk about that later. I have a whole PowerPoint presentation on implants. You do need to review your health history again. Here it is again. Health history is important. Does your patient have a pacemaker? Certain types of pacemakers you cannot use the ultrasonic with. So again, these are just some things that, just review the pros and cons and know the differences between the both. Okay, notice the dinosaur in the upper right-hand corner of your slide. So this should tell you that this is old dental terminology, but we still use it in practice today. But the next couple of slides, we're going to talk about some terminology, and you need to know the definitions of these words. And these are your big words, your dental words that you are going to talk to your fellow hygienists and dental team. We all need to be on the same page, and the new terminology and the old terminology are interchangeable, but for now, scaling is the instrumentation of the crown and root surfaces. Root planing is the intentional removal of the cementum. That is an old, look at the dinosaur, old way of thinking, because back in the old days, refer to the dinosaur, they used to think that you had to really just completely remove cementum in order to remove bacteria. Well, we know now that biofilms are easily removed from the surface of the cementum. So although we still root plane, we're just really more cautious now. We take gentler strokes. We're really just more careful now. with our precious cementum. So how silly does it seem to think of the statement periodontal debridement as being new? However, in the realm of dental hygiene, it is relatively new way of thinking. And this is what we're still talking about, non-surgical periodontal therapy, chair side, usually completed in a single appointment. We're talking about your adult prophy, okay, maybe even your child prophy. And it does not include the deliberate removal of the cementum. You'll see down at the bottom, deplaquing. There's some codes and some things that you'll learn when you're out in private practice, different ways to code and bill procedures that you perform. But deplaquing is just the disruption or removal of subgingival microbial plaque. So just know the difference between SRP and then the periodontal debridement terms. Speaking of the ADA insurance coding system, I'm going to be giving you guys some codes to memorize. We found from previous course evaluations from students that have graduated, but they felt that they didn't know dental codes enough going into private practice. So I will make sure that I will give you some codes that you will be memorizing. I know that they're on the final exam, so I'll be getting those posted shortly. And it's your specific codes where we're talking about the adult prophy, SRP, SRP 1 to 3 teeth, things like that. So I'll get that posted on the BB Learn shell, and you guys can start memorizing those. And it's just really good to know the codes moving, after graduation. So you know what's going on when you're new to an office and you want to feel like that you know what's going on. So you're on the same page, if you will. I guess what we're talking about here is some more terminology considerations that came about that are probably in your textbook, but maybe were not in the textbook last semester. They added the code for gross debridement. And sometimes when a patient comes in, they have so much plaque and calculus and buildup that we have to do a gross debridement before we can even do any kind of periodontal assessments. Well, obviously there's a billing code for that because the dentist is going to get paid. After all, the hygienist spent probably an hour doing this. So that debridement code is D4355, gross debridement. Again, this is a code that you need to memorize. You may be tested on your final exam for this. And to kind of go with this slide, in under week 10, you'll find a video that I posted of a gentleman that hadn't brushed his teeth in 20 years. So you might want to go watch that video if you haven't already. Okay, so we bring our patient in and we do our assessments and we complete our non-surgical periodontal therapy. Well, what do you as clinicians expect to see following, your hand instrumentation or your ultrasonic instrumentation? What kind of healing response would you expect to see? Well, don't expect miracles, however, because we know that tissue healing does not occur overnight. There's no formation of new alveolar bone, there's no formation of new cementum, and there's no formation of new periodontal ligament. However, we would hope to see a reduction in bleeding on probing, clinically the tissue looking healthier. Okay, that's what we're kind of looking for at that initial reevaluation appointment after non-surgical periodontal therapy. But again, we're not going to see new alveolar bone, new cementum growing back, and new periodontal ligament happening overnight. It's just not going to happen. So in regards to what we hope to see during that reevaluation appointment, the shrinkage of soft tissue and shallow pocket depth. Now remember, when you do your initial probing depth evaluation, and you have maybe a 4 or 5 millimeter pocket. Hopefully, it's a pseudo pocket, and when we've cleaned and removed the bacteria, the tissue is able to kind of shrink back and kind of tighten back over. That is a goal. If you get to see that, that is great. That is our goal. Good for us. We did our jobs. over time, you know, the long junctional epithelium is readapting. It's reforming back to the tooth because you've got to the base of the pocket, you've removed the bacteria. I don't want you guys to get your hopes up and think that when you bring your first patient back for a reevaluation that they're going to have all of this wonderful stuff happening in the mouth. Yes, they do, but you know, again, if they have a true 6mm perio pocket, you're not going to get great reattachment. Does that make sense? We're talking about pseudopocketing where you might see that shrinkage over time. We want to see less bleeding, less inflammation, and we want to see, this is a big key factor when you bring your patients back for the re-care appointment to reevaluate. We want to see that their home care has possibly improved, especially if they have, you know, moderate plaque, moderate calculus and such. We want to see that their home care has improved. And if it hasn't, again, this is your time to stress OHI, OHI, OHI. This picture is illustrating a pseudopocket that has shrunk, and in this particular case, led to recession. So sometimes shrinkage of the soft tissue can result in recession. Okay, stop the presses. This is a great test question for those of you that are curious. The primary type of healing after periodontal instrumentation is through the formation of a long junctional epithelium. So a long junctional epithelium is the type of primary healing after periodontal instrumentation. Test question, note card, test question, note card, test question. Again, this picture is just kind of illustrating that I don't want you to expect to see a significant amount of changes in soft tissue, okay, after non-surgical periodontal therapy. Okay, so you have successfully completed your non-surgical periodontal therapy. Now what? Well, we've already discussed that this is a major step that is usually overlooked in private practice only because it costs money. And a lot of insurances won't pay for the reevaluation appointment. However, it is important to consider what's going on in your patient's mouth if it's the first time you've treated them. You know, is it going to work? Did it work? You know, so don't, you know, you can fight for this as a clinician when you graduate and move on to the real world. You can bring your patient back for that reevaluation appointment. Bring your patient back in clinic and look and see, did you improve their oral health? I know that you guys do a case study and you have to do that reevaluation appointment. We should be doing this with every patient. Does it happen? No. We can make it happen if we want to. So just keep that in mind, that the reevaluation appointment is super important, just as, you know, so we can keep a track of what's going on in their mouth. Okay, so when do I bring my patient back for a reeval? Well, professionals state that you usually want to bring your patient back between 4 to 6 weeks after completion of periodontal therapy, only because if you are bringing your patient back too soon, so less than 4 weeks, things might not be healed properly. They could still be inflamed and you're reprobing, and they might be bleeding only because they're still, you know, not healed correctly from your treatment. So reevaluation appointment is usually done between 4 to 6 weeks. If you wait longer than 6 weeks, you know, the patient has had time to not keep up on OHI, and they might fall back into old habits. So, you know, your assessments might not be reflective of the work that you did. Does that make sense? So 4 to 6 weeks. So what do we do during this appointment? Well, you're going to reprobe, you're going to check for bleeding, and you're going to check for inflammation. And you're going to compare it with your baseline data. And that's why it's so critical to take the baseline assessments when you first see a new patient. And then you're going to decide on your plan. Is your patient ready for periodontal therapy? or I'm sorry, periodontal maintenance therapy, or do you need to retreat some areas? So this is kind of the critical point in treatment. Is my patient ready for perio maintenance, or do I need to retreat an area? Down here at the bottom, you're going to see where it says that the best criteria for looking at if the patient responded well is tissue response, absence of bleeding on probing. Okay, so that's why it's really important to redo your perio charting when you bring your patient back for a re-eval. Again, these are the steps in the re-evaluation appointment. And again, I can't stress enough that we're looking for that reduction of inflammation, that reduction of bleeding. Do I feel confident that my patient's ready for periodontal maintenance? Do I need to refer to a periodontal office because something just isn't healing correctly? So these are kind of the steps that we go through during that reevaluation appointment. It's a fast, quick appointment. It isn't a whole 2-hour appointment. It's basically you're coming in, you're seeing your patient, reviewing medical history, you're going to reprobe, you're going to compare your data, and then you're going to decide, did it work? Did it not work? What are my next steps? Do I need to refer? So that's really an important part of the process. So during the reevaluation appointment, if you find an area that's non-responsive, that you still feel it's bleeding or is still inflamed, check to see if there's still calculus left behind. At this point, you would want to re-clean that area, that specific area. Let me stress that at the re-evaluation appointment, you're not doing an entire full mouth debridement or full mouth cleaning. You're just checking. But if there is an area that you find that's still not responding as well as you hoped it would, by all means, go in, take a couple swipes with a hand instrument, check to see if you left anything behind. Now, I've stressed before in previous lectures that, we're not perfect. We leave calculus behind. Maybe that was the pocket that by the end of that appointment, you were tired, you were done. Maybe you left something behind. So now's the time at the re-eval appointment, just get in there and just give a couple swipes and see if you can get anything to come off of that tooth surface, because that's the whole idea behind the re-evaluation appointment. And at the end, I always, this is just my personal practice behavior. At a reevaluation appointment, after I've probed and I've reevaluated, possibly cleaned a surface or two, I'll polish my patient, because they appreciate that. It makes them feel like they paid for being there and they received treatment. So, always consider polishing if you can at the end of a reevaluation appointment. Again, that's personal preference on my part. It just depends on how you run your practice. Okay, dental hypersensitivity. This is a topic near and dear to my heart because I experience this with every dental visit that I have. I have some areas in my own mouth that I cannot stand for an instrument to be on. So I guarantee you, if you haven't ever experienced a patient jump out of your chair and cling on to the roof, the ceiling of your practice, it's coming. It's going to happen. Sometimes they scare you. They jump so much. They move your instruments out of your hands. This is a hot topic. Patients sometimes will avoid dental practices in general because they already know it's going to hurt. And they're preparing themselves for the area in their mouth where they know it's going to hurt. So it's important to know what it is, how to maneuver around it, and how to treat it. So we're going to kind of maneuver into that topic right now of dental hypersensitivity. Okay, dental hypersensitivity, what is it? Well, textbook says it's a short, sharp, painful reaction that occurs when an area of exposed dentin is subjected to mechanical, thermal, or chemical stimuli. So what does that mean? Well, a patient can be sensitive to a toothbrush bristle, a fingernail, any kind of mechanical stimuli, metal, wood, it can be their own body doing it to them, like using a fingernail to kind of poke around on a gum trying to get some popcorn kernel out can cause an issue. Thermal stimuli, that's the cold sensitivity, so ice cream, cold drinks, things like that. The chemical stimuli, I don't come in contact with that a lot in private practice, but the textbook gives an example of grapefruit. If you think of grapefruit, it's acidic, so maybe that has to do with maybe acidic fruits, vegetables, foods, things like that. It's most likely associated with people or patients that have gingival recession. It can be localized or generalized, like the circle in the box states here. But I just want to let you guys know that not all recession is hypersensitive. I see patients quite often with generalized recession that have no sensitivity. So it just depends on the individualized patient. So it's our job to recognize it and address hypersensitivity when possible. So if you need to explain to your patient on what is causing the dental hypersensitivity, you can liken it to little nerve fingers. The odontoblastic cell processes, of course, your patients are really going to understand that terminology, right? Liken it to little nerve fingers. They're left exposed because the cementum is missing, okay? So if the cementum is missing, those little nerve fingers are exposed to the elements. What are the elements? Water, air, heat, cold, chemical. I mean, there's a million things to the individual that can cause this sensitivity to occur. It can also be likened to or caused by, enamel wearing away, abfraction, fractures in the tooth. Dental caries can cause some sensitivity, and also restorative work can cause patients to experience dental sensitivity. So just let them know if you want to liken it to the little dental tubules happening. I like to call it little nerve fingers. The little nerve fingers are exposed, and that's what causes them to jump out of the chair or feel uncomfort or discomfort when they are being treated in the chair. So sometimes our patients are so sensitive in some areas that we struggle to treat them. Is it okay to skip that area? No, ethically, we're supposed to clean every surface of every tooth that we can. So sometimes we do have to administer a local anesthesia to clean a patient. I don't like to do that if it's just a recession kind of hypersensitivity issue, but just know that is an option. But again, it's that smear layer, the smear layer being gone off the tooth that causes the hypersensitivity. So there's some things that we can do. And in clinic, we can apply Gluma, which I do know that you learn in summer. It's almost like a varnish. I don't want to say varnish. I don't want you to get it confused with fluoride. It's almost like a white fingernail or a clear fingernail polish that we can paint over the tooth surface that kind of occludes and kind of smears that area of those dental tubules up so that the patients don't feel the pain. And you can also use fluoride varnish. You can put varnish on beforehand if you need to, and that can help occlude that and cause a smear layer to happen as well. So there's some things that we can do to kind of ease the pain for these patients. Now I will tell you, as a private practice clinician, that there are some areas on certain patients that I don't touch. I will do my best, and we do the best job that we can. But normally in that circumstance, patients will sit down in the chair and they're going to tell you, on this tooth, on this surface, you can't touch it. So you just do your best to do what you can do, okay? But you always want to give your patient the option of some treatment, some medicament that might be able to help it, which in our case, in our clinic, we do have Gluma, And we do have fluoride varnish, which those are great options to use. So let's keep talking about the strategies to manage dental hypersensitivity. I've kind of talked a little bit about chemical management with some product, Gluma in specific, or even fluoride varnish. Of course, you're going to talk to your patient about what's going on in their mouth, and maybe this is the time where you talk about a sensitive toothpaste. We'll get to that in a minute. The laser, treating with laser, I am not super familiar with. I do know that the textbook talks about it, but that is an option for some offices, and you might learn a little bit more about that later. And you can also treat sensitivity with restorative materials. Maybe we put bonding material over it there. You know, we might be able to put a filling on a root surface that will help alleviate that pain. But we're going to keep talking about some other materials in the next few slides that we can use in practice. Okay, so normally when I have face-to-face lecture talking about these topics, as the Sensodyne toothpaste, the Gluma, I bring them in and I show you and we pass them around. I'm not quite sure what you got in prevention, but let's just talk briefly about why these chemicals can help, or these medicaments, if you will, can help block those dental tubules. It just depends on what they're made out of. And when you're looking at these toothpaste that help prevent, you know, they're marketed as sensitive, Sensodyne, Colgate Sensitive, Pro Enamel, things like that. I always recommend looking at the ingredient of what's inside. So the active ingredient of Pro Enamel is 5% potassium nitrate, okay? And it does have some sodium fluoride included. But when you're trying to recommend to your patient something that will help with sensitivity, you want a product that has potassium nitrate included. Potassium nitrate blocks sensory nerve activity at the pulpal end. So the little nerve fingers are kind of extending out where that cementum and that dentum is exposed. And then you have that Sensodyne toothpaste with the potassium nitrate involved, kind of blocks it and smears it. And that's what helps keep the sensitive area. That's kind of how it works, is the potassium nitrate blocks that nerve ending. Now, if you kind of look to the bottom right hand screen and you see the Gluma, that is exactly what our Gluma looks like in clinic. And again, I do believe you will be learning how to apply this in summer school. But again, it's almost like I like to liken it to fingernail polish. So you kind of open up the little blue bottle that it comes in, you kind of break it off, and then you have a little, see the little red thing at the bottom, it's kind of like your apply stick, and you just kind of smear it around, and then you'll put it on the tooth surface itself. But the active ingredient of Gluma is 5% glutaraldehyde, okay? And with that, it's also a disinfectant, a preservative, okay? And so what it does is it's just kind of, again, it's a smear layer. It's a smear layer. You have to be really careful with Gluma, and that's why we don't let you apply it until you learn about it. You don't want to get it on the gingival tissues. It can burn it. It can cause it to, I don't want to say blister, but I've seen it kind of get discolored. The gingival tissue has gotten discolored before. So it's really careful with Gluma. You have to be really careful with our fluoride varnish. We can be a little lackluster and apply it the way we need to. With Gluma, it's a sensitive application process. So that's why we teach you in summer how to use it. But it's about blocking those dental tubules. Okay, I really like this slide because I think it is super important. Before you start with your non-surgical periodontal therapy, I think it's very important to stress to your patients that with any type of mechanical debridement, there's always the possibility of dental hypersensitivity. So I just want to talk to your patients about that because it's better to be safe than sorry. You know, you want them to know what to expect after treatment. So I think it's always just important to warn their patients that with any treatment that there is the possibility of removal of cementum, removal of, the exposure of those little nerve fingers. So just always talk to your patient. And what do you think that you can tell our patients? Well, I asked the question, what can you tell your patients, or what should you recommend or explain to your patients that they might experience after non-surgical periodontal therapy? Well, you know, we stressed that sensitivity can occur, but in most cases, it gradually disappears over a few weeks, okay? And I always like to tell them if they're experiencing sensitivity after SRP, come in during your reeval appointment, your reevaluation appointment, and you can either put some fluoride varnish, apply Gluma, and try to help kind of, dissipate that feeling that they're having. But again, you can always stress that plaque control is the #1 thing that can help control sensitivity. Because with plaque control, you're removing that acid environment, that bacteria, and all of that that can contribute to sensitivity. I do know that if patients come down and they sit down and they tell me that they are sensitive, I always give them the free Sensodyne toothpaste samples that we have. But you need to keep in mind with Sensodyne, it does not happen overnight. And you know, if it's a specific case where you are doing initial assessments, but you're not treating the patient the same day, and they're exhibiting sensitive areas, give them Sensodyne or recommend a toothpaste with the potassium nitrate in it, but they need to be on it about 2 weeks before treatment. 2 weeks is the minimum. It's got to build up. It has to build up its immune response, I guess, and for lack of another word, it has to build up that smear layer, okay? So the special toothpaste, they do help people, but you need to let your patients know that it's not an immediate result. In the long run, if your patients, after treatment, if you'd like to recommend if they're experiencing sensitivity, tell them to call the office if it continues. Bring them in. We can apply some Gluma or some varnish. Okay, so the next 3 slides are talking about embrasure types. So you need to know the definitions of type 1, type 2, and type 3. Currently, you're looking at embrasure type 1, and you just need to know that that's healthy papilla. Embrasure is filled completely by interdental papilla. Nothing is missing at this point. Okay, so now we're currently looking at an embrasure type 2, where approximately 75% of embrasure space is still occupied, but you can kind of tell there's a reduction in that papilla height. So, you know, dental floss might not be the perfect interdental aid for this type of patient. This is when we might want to look at recommending interdental brushes or wooden toothpicks to kind of help with our plaque removal. Okay, so here is embrasure type 3, and you will notice by the picture at the bottom that the interdental papilla is missing. So this is definitely where you would want to, you know, recommend an interdental brush. An in-tuft brush are effective for this type of patient. In a few slides from now, we're going to look at some different dental aids, but definitely dental floss alone is not going to be the best plaque removal tool for this type of patient. This is when you want to look at some different brushes or some different techniques for this patient. Okay, well, there is a lot going on this particular slide. It's showing different dental aids to use for the particular patient that you have. I see some orthodontia, I see some tight, healthy tissue, some pictures showing here. And how do we know what to recommend? how do we know what tools to recommend for our patients? And again, I so wish we could be face-to-face because I always raid CVS and Walgreens, and I bring in all these great dental aids that, you know, we don't have in clinic that I like to pass around, and we play with them a little bit. But, you know, it wasn't meant to be. We're going to just look at some pictures and we're going to talk a little bit. But again, when you're recommending a dental aid, look at their OHI history. When they fill out their original medical history, what do they tell you that they're already doing? If what they're already doing isn't working, and you can tell usually by doing your disclosing or just looking in their mouth, this is when you might want to assert maybe a different type of dental aid that might help them. You want to look at also their dental history. Do they have furcation involvement? Their gingival assessment. Do they have flappy pockets? Do they have tight tissue? You want to look at their tooth position. Are they crooked? I mean, is it hard for them to get in there and clean? Definitely look at the embrasure spaces that we just talked about 3 slides previous. Look at their probing depths. Definitely disclose. That's the best thing you can do to show them their biofilm. But you also want to take into account their personal factors, such as disability or dental knowledge. So when I say disability, I'm talking about, can they hold this instrument in their hand? Can they get it to their mouth? And can they use it appropriately? Okay. And then, of course, I stressed earlier, if you're going to recommend a product, definitely you need to know how to use it, and you need to teach your patient how to use it. And under week 10, you will find a video from a periodontist that I follow quite frequently talking about some different dental aids. So please take the time to watch that video under week 10. Okay, so in this particular slide, these are some products that I do know that our dental clinic has. Down at the far bottom right, that is Super Floss, which is, I love it. I love it for bridge work. Anywhere there's a pontic, it really gets in there and cleans really well. Kind of in the middle where the round toothpick box is with that little pick holder. We still have those in clinic. Those are very old school. I think that whoever was our clinic director a million years ago bought cases of those, so we still have those in clinic. But they're still viable, and some people love them, and we still have them. And again, I wish I was there with you guys to pass them around. In the upper right-hand picture of the slide are the Stimudents, and these are basically just modified toothpicks. I tell a story where if you're afraid to clean around a crown, grab a Stimudent and use this to debride around a crown. If you're afraid you're going to damage that surface of the crown, these are great tools to use. Some patients love them. I particularly love, my favorite thing in this whole slide are the soft picks. In my office at work, you can find I have smuggled a whole box out of clinic. Don't tell Mrs. Harris. I use them every day. They're very soft. They're non-gentle. I do have embrasure spaces myself. Patients love these, love them, and they're a great tool. They're gentle enough to use with most every patient, healthy patient. Now you will get to the patients that have wider embrasure spaces that, you know, it just doesn't cut it. You need that thicker Christmas tree looking toothpick to use. But I do like a soft pick. And again, I'm sorry that I can't pass this stuff around for you guys to play with this semester. Hope to make it up to you soon. And of course, lower left, that's your electric toothbrush. We like to stress the importance of using an electric toothbrush, only because patients just don't brush for the full 2 minutes with manual toothbrush. So here are some different tools to use. And again, please go watch the video regarding different dental aids found under week 10. So this slide, I left it in, and basically, you know, this would have been after we passed around some of the dental aids to use and played with them. But just kind of look at the pictures 1 through 8 and think to yourself, well, what would I recommend for my patient? Well, number 1 looks pretty healthy, tight tissue, right? So maybe some dental floss, you know. you look at pictures number 2 and 3 and 4, and anytime that you can notice that your eraser space is missing, is when you might want to go in a little bit step forward and maybe go into, you know, the brushes, the little Christmas tree shaped dental aids that we give. Number 6, you could use, if they weren't sensitive, the Stimudents, the little orange toothpicks there to kind of pick away at the plaque areas. Number 7, that's showing a dental implant. That's the fixture that's protruding from the gum tissue, and we talk more about that soon. But my number 1 favorite thing to use for dental implants is the Super Floss. It gets down in there, you can floss really good. It grips around the fixture shape, the threaded shape of the fixture that's embedded in the bone. I love it. And number 7 to the far right, that is a bridge kind of situation. Again, the Super Floss would be really great in that situation. A floss threader, definitely, to get underneath that bridge. So just look at this and just think, if this was my patient, what would I recommend? And how would I teach them how to use it? Thank you for listening to my first lecture, I guess, online. I've never had to do this before, but I appreciate you participating today. Again, if you have any questions on any kind of terminology or just general questions about this lecture, please email me via VVLearn. Again, I'm going to offer a 2-point extra credit activity. The first person that responds to me and tells me how many times I said during this presentation will get the 2 points of extra credit. So you guys keep hanging on, and I'll talk to you soon. Hope everybody's doing great.